Have you ever seen a patient with a gap between their upper front teeth and wondered, will it close by itself or does it need treatment? Today we'll solve that clinical mystery, the median diastema. Clinical overview. A median diastema is the space between the two upper central incisors. It's common during the mixed dentition stage, sometimes called the ugly duckling phase. In many children, the space closes naturally as the permanent canines erupt. But in some cases, it persists, and that's when we step in. Etiology. Causes vary. It may result from dentoalveolar disproportion when the teeth are too small for the jaw, or from habits like digit sucking. Missing or peg-shaped lateral incisors can also create spacing. Sometimes supernumerary teeth or an enlarged labial frenum are responsible. Remember, always check family history, as hypodontia can run in families. Diagnosis. Start with a thorough examination. Check the frenum, perform the blanching test by lifting the upper lip, and use occlusal or periapical radiographs to look for supernumerary teeth or cysts. Palpate the area and inspect for bone notching between the central incisors. Management. If the gap is less than 2 mm and the canines haven't erupted yet, reassure the patient. It often closes spontaneously. If larger than 4 mm, or if there's a lack of space for the laterals, plan early intervention. Eliminate causative factors. Stop digit sucking habits and remove any supernumerary teeth or pathology. Orthodontic closure can then be done with fixed or removable appliances, followed by a permanent bonded palatal retainer to prevent relapse. In some cases, perform a frenectomy during space closure, and if lateral incisors are small, consider restorative veneers for aesthetics. So, when faced with a median diastema, think cause before cure, investigate, correct the etiology, and then close the space. Clinical problem solving isn't just about moving teeth, it's about understanding biology and behavior. Clinical meaning. Median diastema. A median diastema is a space between the upper central incisors 1-1. It can be developmental, pathological, or due to an underlying anomaly. Orthodontic understanding. Step-by-step 1. Etiology causes. Orthodontists categorize causes into developmental, ugly duckling stage, normal spacing in mixed dentition around ages 8-11 that usually closes when canines erupt. Dentoalveolar disproportion, jaw-tooth size mismatch, missing or peg-shaped lateral incisors, often congenital absence of twos, lateral incisors. Supernumerary teeth, especially mesiodons, can be conical, tuberculate, supplemental. Habits. Digit thumb sucking can push incisors apart. Pathology, cysts, odontomes, or tumors. Frenal attachment, prominent labial frenum inserting between incisors. Periodontal issues, juvenile periodontitis, hereditary factors, family history, hypodontia. 2. Examination. Orthodontists assess. Clinical inspection, check the size and position of incisors, presence of frenum or blanching on upper lip stretch. Palpation, feel for notching in interdental bone or thick frenal tissue. Radiographic views, occlusal periapical X-rays or DPT to rule out supernumerary teeth or pathology. Dental charting for missing or extra teeth. 3. Investigations, radiographs to confirm if supernumerary or missing laterals are present. Family and habit history, digit sucking, spacing pattern. 4. Management approach. Orthodontists think in stages. Observation. If the diastema is less than or equal 2 mm and before canine eruption, no treatment, often closes spontaneously. Intervention. If more than 4 mm or if no space for laterals 2s or persists after eruption, treatment needed. Treat underlying cause. Remove any supernumerary tooth or pathology early. Stop digit sucking before starting orthodontic work. Consider frenectomy, surgical removal of frenum, only after space closure if frenum prevents stability. Orthodontic closure, removable appliance, example, holly with finger springs, or fixed appliance, brackets, wires. Permanent bonded or palatal retainer to prevent relapse. Restorative correction, for peg-shaped or missing laterals, veneers or composite buildup may be needed. 5. Prognosis. Most developmental cases resolve naturally. Structural causes, missing extra teeth, large frenum, require combined orthodontic and sometimes surgical management. Retention is critical. Bonded retainers are standard to prevent reopening. Summary: clinician's mental model. Step 1. Diagnose orthodontist's thought. Why is the space there? Developmental versus pathologic. Step 2. Investigate orthodontist's thought. Radiographs, habits, family history. Step 3. Decide timing orthodontist's thought. Wait if precanines, treat if post-eruption are more than 4 mm. Step 4. Treat cause orthodontist's thought. Remove obstacles, stop habits. Step 5. Close space. Orthodontist's thought, orthodontic appliances plus retention. Step 6. Maintain orthodontist's thought retainers plus or restorative finishing. If this helped you visualize the case better, hit like, share it with your classmates, and subscribe for the next episode on problem solving in orthodontics.